Thanks very much to be here. It's a delight. In 15 minutes, I'll tell you a journey of about 5 years. They say an epic year is like a dog year. It is equivalent to 7, so you're probably going to hear quite a lot. This is a digital talk, but what I'm going to talk about is clinical and social care transformation. It's just enabled by digital. I'll give you some background about Northern Ireland. None of this will surprise you. It's a population of nearly 2 million. It spends about $7.5 billion on its health service, which is 52% of the gross national product. We will not have any more money in real term, and it maybe says more about our gross national product. We'll have 80,000 staff, 6 trusts. One of those is the ambulance service, so mainly 5 care deliveries trusts, 320 GP practices, 368 dentists and 528 community pharmacists to integrate with. It's a pressured health service. It provides less productivity per head of population and while putting in more money per head of population than anywhere else in the UK. It has had multiple reviews of service, which really have progressed to different levels, and there are ongoing public inquiries into health. So there was the drive behind this was about clinical governance and about safe care. We provide a range of social care and day centres, and they are all also on the platform. Ultimately, 1.5 million outpatients, 250,000 inpatients, and almost 300,000 day cases. Okay, Northern Ireland's made up 5 trusts. To date, we've done the one in red, which is the South Eastern Trust, the darker blue one. I'm actually red-green colourblind, so excuse me if I don't get this quite right. We've done the Belfast Trust, which is the regional centre, and we've just completed the Northern Trust, the darker blue one, and obviously at the top, a week ago. Epic implementations are not without challenge. It's just disruptive transformation, and it requires everybody in the service to be involved in this. This is not a digital implementation you do onto a service. It's about having clinical leaders involved and having managers and all members of staff engaged in it. An implementation of an EHR impacts everyone in the service. Our scope of program is hospital care, mental health, community care, adult social care, and children's social care. Mental health, community care, and children's social care are aspects of the EPIC program which really have not been rolled out in many places. They do social care in the Nordic countries, but not in the UK. Okay, just to make it difficult, post-COVID, we decided to do lots of things at the same time. So we did an individual patient identifier, an EHR implementation, a new lab system, a new radiology system, and in the background, some HR work, a back office IT work, a blood products transport system, an e-pharmacy system, and a data institute. This was a complex piece of work because all of the implementations have different cultures and different implementation strategies. And the real trick was to align these all at one time. So when we were going live with the EPIC platform, we were also managing a go live for a sector implementation and a clinicist implementation in the laboratories. I don't think anybody in their right mind would do that in retrospect, but to be fair to the staff, it was managed and it was managed well. But it did take all hands on board. And when I say that, the governance process within the trust would start out at 180 days out, and we'd have a full day meeting to go through the risks and mitigations. And we were careful to pitch this at not just the digital enabled or the digital keen. This was about managers in the service and the clinical leaders in the service coming in and being involved in this process. And you'd work through your mitigations on a monthly basis until that you were assured that you could go live with a safe go live. Okay, how long did it take? We did some pre-work just coming out of COVID, but the main piece of work and the most important piece of work is this thing called WAFWT, Workflow Walkthrough and Configuration. That was about agreeing how we provide services both within hospitals and community care and in social care across Northern Ireland. How do we do this to the best of our ability, the same way across 5 different organisations? They're all in the same HSCNI, but of course they don't do anything similarly. Some services, such as cancer services, had a long history of doing things along pathways and protocols. Laboratories were similar, but lots of services differed in a greater way. What this actually meant that when we go live with the Epic implementation, we're doing two things. People's day-to-day work was changing slightly, and then they were putting it onto an Epic platform. And this was really, really important. So we had to have a lot of business change analysis. And when we were doing training, we were not simply training people to use a computer. We were training them in situ, in user labs, to work differently and to make sure they were safe implementing the Epic platform. The training teams developed, Epic gave you a playbook, and they actually took this and ran with it. And they moved the training from a classroom and added in user labs and in situ training, and it very much models the type of training that's done in medical education, so that people actually, those who work together, train together. And that helped with the changes in patient pathway as well as the implementation of the platform. The first go live was always the hardest, and stabilization was not without its challenges, but subsequent go lives have gone very well. We're now 7 or 8 days out from the Northern Trust, and it's a very stable environment. And so I think that's a testament to the people in the programme, and especially the people in the Trust. The main pillars we cover these. I'll not belabor this, but there's change impact, and it involves everybody. We think we got everything right, but we did not. This major impact in administrative staff, and the scope and breadth of that wasn't really appropriately called out. So you have a lot of staff who are anxious about their future careers and what their role in the future would be. So we learned from the first implementation and changed that. It is really about clinical transformation, and that's a really important point. The people who need to lead this aren't the digitally funded clinical staff. It's actually the clinical leaders in the community services and social work in the hospitals, and you have to have them on board, and you have to have them leading it. We funded staff additionally, and I'll come on to that. But we purposely also funded lots of part-time staff throughout the Trust to make sure they had time and space to provide that leadership. Okay, this is the governance map, and I'm sorry, it's a bit. I always joke it's a bit like the Catholic Church, but hopefully more transparent. It has to be absolutely inclusive, and so each trust would have a governance process which we would input to, and the trust would input to the Encompass Delivery Board. There are very important other groups that we have. We have professional leads groups. We had a joint negotiating group with the unions to make sure they were comfortable about the change for their members, and we had the Encompass Engagement Council. That was 32 expert patients, and they were given the scope to drive the patient app. And they were on to challenge the future and change how we do. Healthcare in Northern Ireland is very patriarchal. It's often done on to people, and people don't usually get access to their own information, notes, etc. So they're potentially purely informed, and our aim is to change that. So, and I think you've heard some of the talks, especially the first talk from Emer, that the information belongs to the patients, and we have to treat them as partners in care. But we live in a busy environment, and in the bottom right, we have the training bodies, we have academia. So they're our partners. We have the regulatory bodies, RQIA, you'd have HICWA, the Public Health Agency, the Patient Client Council, and at the top left, we have the hospitals, GPs, and the independent sector. As a result of one of our public inquiries, there was a recommendation made that any patient record system had to be made available to the independent sector. So because the independent inquiry recognised that an EHR was a patient safety tool, and it's essential that there was a seamless sight of that across Northern Ireland. So we're working through the information governance and contractual issues about that. But when we fully go live, every healthcare facility in Northern Ireland in secondary care will be on this platform. Okay, how did we manage the governance? Well, you have to have site-specific experts to design the patient flows, and the green ones are process maps. But that's what we do. How we do is that we had to have focus design groups who actually detailed how you actually do an emergency cesarean section the same way across Northern Ireland, how you do varicose veins the same way across Northern Ireland, how you manage your endoscopy services. And so some of this was self-evident and some of it did not require a lot of change, but we had to have agreement across Northern Ireland because we were now moving from 5 potentially different, slightly different ways of doing things to one system that meets need and hopefully was best care. Okay, financially, we had a business case that undercalled the need for clinical staff. So we stopped at one point and had an addendum and got support for an addendum for an additional £110 million. That was deliberately targeted, getting additional clinical staff in, because while trusts are willing to be partners, they can't do this without resource. They can't do this in a busy time where bed occupancy is routinely above 100%. So it has to be funded appropriately, and people need time and space to do that. And we were supported in doing that. And these are not huge numbers. So they add up to about 31 for the small trust and 62 for the Belfast Trust. But that's just the tip of the iceberg. These are the people driving it. From a full-time point of view, you actually do require a trust going live to make this their #1 priority for 12 to 18 months. And that is a very big ask of a trust, because it adds in greater risk, greater demand, and greater stress, because all trusts will be dealing with, patient waits, they'll be dealing with ED problems, they'll be dealing with waiting lists, etc. Okay, the overall numbers at peak, we had 310 billed staff, we had 205 funded clinical staff, but the trust would have funded multiple other posts. So it's not an unsubstantial financial cost above and beyond the contract with the vendor. That decreases to 190 posts, or 196 it should be, for the life of the program. So what you have billed staff to make sure that you manage the implementation going forward for the next 14 years, so that as change is required, as healthcare develops, as patients' expectations change, you can meet that need. Okay, this is some of the learning so far. We've learning around training and upskilling, data analytics. The EPIC platform is very much based on an American secondary care model and does not necessarily align with NHS requirements. Now, they are doing some work to improve that. I think they're a bit slow in getting there. The admin workflows, it's an American model where most of the admin workflows are done by physicians, and doesn't meet the hybrid model of the NHS, where we have multidisciplinary input to the workflows, plus we have a lot of admin input, and we didn't want to end up having surgeons being very expensive secretaries. So we've got a hybrid model to make sure that doesn't happen. Post-live planning, work doesn't come back to normal activity unless you manage it. Data doesn't flow from the system unless it's actively managed. Data validation, or the staff using the system appropriately, is compliance as it should be? Are things called slightly differently now? Was the data in the past possibly not reflective of the real world? Everybody has great faith in the past when it's not actually necessarily so. So, governance of a program with multiple partners, it has to be comprehensive and inclusive. It has to be. The board was a delivery organisation. It wasn't representatives from the Northern Trust or the Western Trust. They were there to deliver the programme. It's an advisory board, and the SRO is responsible. So at times it was a lonely place. It has to be a compassionate culture, and the culture was not as it should be at the start of the programme. There was a lot of adversarial behaviour. There's a lot of anxiety about whether this will be a success or not. But compassion is not enough. You have to deliver the outcomes, and you have to support people to do that. So when I say don't simply empathise, you have to find solutions. You have to work in a very agile way. And where there are problems, what we did, we would go to other trusts and bring people from them. I'm about to run out of time. I'll just quickly mention social care and information governance. It's a different world. You can't apply the standards of information governance and expectations of how people, doctors and nurses work, to social workers. They're driven by legal and quasi-legal statutes, and the nature of information governance in social care is different. Often the information is about other parties, family members, and it may be difficult information. So we had to evolve the platform to represent that. So we're currently building a family functionality on the Epic platform, which means that we have to decouple that bit so that they will implement fully a couple of years behind us. So far, we've got a lot of, I'm going to run out of time, so I'll just skip through these. This was from the Southeastern Trust. This is an artist drawing what the staff felt after the implementation. It was one of the most positive things they've done in healthcare, because day to day, everybody's just doing the same. The trolley waits are there, the waiting lists are there, and they were given an opportunity to change the service that they deliver. They were asked to say how this should be for them and put it on a digital platform. And they were empowered and they were trusted. And I think it was really positive for the staff, and it was a privilege for myself. So I'll leave it at that. Thanks very much.